Okay, as you all know, it's very common. At least 1 in 1,000 cases you'll see each year. It's more common in men than women, 4 times at least, and it's more common in the younger population between age of 20 to 35. There is a nomogram, you can use it for the recurrence rate of kidney stones. Usually after the first episode, there is a chance one in like 50% after 1 year, and 1 in 3 of the patient who have a kidney stone to have it in 3 years, and 1 in 2 will have it at 10 years at least, from each patient who already have 1 episode of kidney stones. We can use the ROX nomogram. That's a series of questions and points. If it's 1 in 150 and more, there is a higher chance of recurrence, as you can see here. For 10 years, I would say the point is 150 point. At this point, there's a higher chance of, it will increase exponentially the more times, the more points he have, according to the nomogram. Regarding stone formation, there is many different reasons and risk factors. For example, if the urine volume is less, there is a higher chance of forming stones. If the pH is low or acidic, there is a higher chance of having kidney stones, except in struvate stones. Also, if patient have hypocitraturia or low citrate, you have a higher chance of having kidney stones. Some infections will have a higher chance, urinary tract infection will have a higher chance of having kidney stones. Also in case of concentrated urine. There is more than one theory about how kidney stone develop. As I'm sure most of you know, there is a Randall's black. The patient urine is prone to have crystals in his urine. So these crystals aggregate on a Randall's black, and with time, with less urine and more concentration, they will aggregate more and form a kidney stones. And there is another theory, supersaturation. It's a similar idea. The urine is concentrated, and the patient urine is prone to form crystals. So these crystals will collapse together and form a kidney stone. Presentation, I'm sure you all know, it's either they have loin pain, renal colic, we call it, sometimes mostly asymptomatic actually. They may have hematuria, microscopic or macroscopic, pain anywhere, depend on the site of the stone. Where is it in the urinary tract? And also sometimes they will have a urinary tract infection, dysuria also. And depend on which side of in the urinary tract they will have the symptoms. There is many types of kidney stones. Thank you. There's many types of kidney stones. The most common, of course, 80% at least are calcium stones. They can be divided into subtypes like calcium oxalate, calcium phosphate. There is uric acid stones, struvate stones, cysteine stone, which is rare, and other kinds of stone. For example, there's many drugs can have kidney stones also. Some of them, the most common for us as an internist is actually antiviral, especially acyclovir and some other medicines. Sometimes diuretics have a higher risk, high vitamin D ingestion, and other medicines. You can see here some of the list. Calcium stone have many risk factors to develop. For example, if they have hypercalciuria in the urine, hypocitraturia, or hyperoxaluria. All these are risk factors, and the most common of these are hypercalciuria, around half of their patients will have. And actually, many patients, we cannot find anything in their 24-hour urine test. They'll be all normal. Either flow collection is wrong, or the diet has changed before he did the collection. And as you can see, the normal range is 7.25 millimoles per day for a man and 6.2 millimoles per day. Depend on is also your lab reference. Also, 1 in 3 at least will have hypocitraturia. Hyperoxaluria, I will talk about it more later on. It can be enteric, it can be dietary, it can be idiopathic, and there is unknown or unclassified also risk factor for having kidney stone. For hypercalciuria, it can be either idiopathic or no specific reason. It can be secondary. Secondary, also there is many causes. I can spend 1 hour for each cause and how to differentiate it. So I'll talk about the most common. Most common is hyperparathyroidism. Around 5% of all stone formers will have hyperparathyroidism, but not all cases of hyperparathyroidism will have kidney stones. Only 1 in 5 they will have it. Also, there's other disease like granulomatous disease, sarcoid. I'm sure maybe we don't see sarcoid patients as urologists, but we see them. They have also high calcium. Some of their cells, the macrophages, will secrete vitamin D like hormone. They will have hypercalcemia and high calcium in the urine also. These are some also of other causes can cause hypercalciuria, hyperthyroidism, renal tubular acidosis, high vitamin D, malignancies, lymphoma, leukemia, especially if they start taking their chemo or radiotherapy. They will have tumor lysis syndrome. They will have also high calcium in the urine, metastatic tumors, especially in the bone. They have high calcium because of the bone demineralization. And there is other causes like nephrocalcinosis and genetics. It can be either medullary or cortical. There is no specific treatment for this condition. We just need follow-up with the nephrologist and with you guys as the urologist. For calcium stones, I'm sure you see in the gross form of the calcium oxalate stone. These I only saw a few times if the patient brings it in the box. Otherwise, you will see it post-surgery or post-shockwave lithotripsy. Calcium oxalate, they have two different types, but most common is dumbbell-shaped crystals in the urine analysis. You can see it under a microscopy. And here in this X-ray, you can see the nephrocalcinosis around the medulla in each kidney, here and here. For the hypercalciuria treatment, there is a general treatment which is increased fluid intake. The idea is not the fluid itself. The idea is to have at least 2 liters of urine per day. And I always tell the patient, make sure that you drink the whole day, not only in the morning or only in the evening. It has to be constant, continuous. The only difficult time is at night when they sleep. They have a higher chance of forming kidney stone when they sleep. Also, make sure they monitor their diet. This is only after we found that they have hypercalciuria. I ask them to monitor their diet, especially reduce animal protein and decrease salt intake. Maximum is 6 grams per day. This is maximum. You can see many references, but I would say roughly in medicine generally is 5 grams, but some reference in neurology, they said actually 6 grams maximum for adults. Of course, treat the cause of the Of course, you have to treat the specific cause of the hypercalciuria. And I mentioned some of the causes. There is many. I can spend 1 hour only for the hypercalciuria by itself, or for differential diagnosis. First line treatment is thiazide. We use, of course, before I start the thiazide, I check his blood pressure, make sure he has no dehydration, blood pressure is okay. Then we start on the thiazide. Make sure to check his electrolyte after 1 week once you start the thiazide. There is other agents like organophosphate, like polymer or chelating agent. We can use them. They are not, some patients cannot tolerate them because of the GI symptoms. There is other like sodium cellulose phosphate, very potent chelating agent. Me, myself, I never use any of these chelating agents. Mainly the thiazide will be enough, and the diet also. If there is hypocyturiria, we need to also administer potassium citrate to make sure to alkalinize the urine. And also I'll talk a little bit about hyperoxaluria. It can be primary. There's more than one type. This is all genetics, dietary or idiopathic, and there is also enteric. Primary, there is more than one type. One type 1 in chromosome 2 and type 2 in chromosome 9. These usually they will have definite family history when you see them. They will tell you, my parents have it already, my brothers, somebody will have it. So from the history you can tell, and they will have it at early age. You'll see them early. Enteric hyperoxaluria can also differentiate into more than one type. The main reason of it is malabsorption for any cause, or if they have chronic diarrhea from any cause. Okay? There is some specific condition, if they have pancreatic disease, if they have inflammatory bowel disease, Also, I found some evidence, research. They have post-bariatric surgery. Some of them will develop hyperoxaluria. We have lots of bariatric surgery here in Kuwait, lots of surgery actually being done. They found the percentage around 1 and maybe 10%, they will have hyperoxaluria. Some cases are so severe that they will have recurrent stone and very high oxalate that they have to reverse the surgery. Some cases, not very common, but they have to reverse the surgery and then it will settle down because nothing else will improve. Treatment for hyperoxaluria, of course, diet. However, the effect is not very good, even if they control their diet. Vitamin B6 administration actually can help because of the pathway of the oxalate breakdown. Calcium supplement, this is some of the cases. In general, we don't give calcium tablet for our patients. This is actually contraindicated. We ask them to increase the calcium intake from the food itself, like natural. But calcium supplement only in cases like this, hyperoxaluria, especially from enteric cause, we ask them to take the calcium tablet with the meal. This is very important because if they take it with the meals, it actually acts like a chelating agent. So the calcium binds with the oxalate and gets rid of it and will not be secreted in the urine. I found some studies also in KI in 2006. Some patients, especially cystic fibrosis, we don't have much here, but in North America and Europe they have cystic fibrosis. They take antibiotic, long time antibiotic, sometimes for 6 months, repeated courses of antibiotic. These patients, they found they will lose some of the normal flora in the colon, and one of the bacteria is actually called Oxalobacter formigens. It actually breaks down the oxalate, so it decreases the amount and also in the urine. So these patients, they found if they give them, there is a specific way they can give them, administer them these bacteria in tablets, and this will actually help them and decrease the oxalate secretion in the urine. Mainly, in general, any patient who take many antibiotic or recurrent antibiotic, we can think of giving them Oxalobacter bacteria that will help them to break down the oxalate. That's the other problem. High oxalate food, actually there is many food, all of you know. Also meat has it, chocolate has it, tea, black tea, green leaves, green vegetables, they have it. So many patients start to hate me when I tell them to make sure to check your diet, decrease the oxalate ingestion, especially chocolate and tea. It's very difficult, I'm telling you. Only if I have only a few patients, they have very recurrent stone. These that actually will stick to the diet. But if they have once in a while kidney stone once a year or something, they actually, maybe they will stick to this diet for a month and then they will ignore it, even fluid. But we are telling them it's easy, but it's not easy if they do it every day for the rest of their life. It's very difficult actually, especially drinking fluid all the time. I'll talk about also hyperoxaluria. There's many different causes of hyperoxaluria. Also, I can spend half an hour at least for these different causes. Most common, all of you know, is gout. Also malignancy, especially if they start taking their treatment, chemotherapy or radiation, they will have tumor lysis. They have high uric acid in the blood, hemolysis, heart failure, kidney failure, some also genetic disorder like glycogen disease, sarcoidosis, severe dehydration. And the treatment, I will talk about the general treatment also later, as I mentioned, fluids. Some cases, if they have hyperuricemia and high uric acid and it's not controlled with diet, we suggest to start allopurinol also for them. Also, sometimes they have normal uric acid levels in the blood, but however, they develop continuous uric acid stones. So in this case, there is benefit also to start them in allopurinol. Also, of course, with diet and other measurements. For hypocitraturia, there is also many causes. Each one have its own workup. There is distal renal tubular acidosis type 1. Any chronic diarrhea symptoms, also they will have hypocitraturia. Taking some medicine like thiazide also will cause it. A diet high in protein, especially animal protein. Severe or very strong duration exercise, marathon, runners, high sodium intake, gout also. usually precipitate, as I mentioned earlier, an acidic stone or acidic urine or low pH urine. They are radiolucent. They don't usually show in the regular X-ray. And they, as I mentioned earlier, they can have normal uric acid levels in the blood or high uric acid level in the blood. And these are some gross pictures of uric acid stones. In urine analysis, they're actually look like diamond-shaped crystals in urine analysis. Risk factor to have uric acid stones, as I mentioned, the most common is hyperuricemia, or 10 or 20% of gout patients will have uric acid stone, but not all of the gout patients will have uric acid stone. So you have to know the difference, because there is so many gout patients, only 1 in 10 they might have actually uric acid stone. There is also rare genetic disorder like Lewis-Nyhan syndrome. Also, they have overproduction of uric acid. So in general concept for differential of hyperuricemia, there is either overproduction of uric acid or oversecretion of uric acid in the urine. Overproduction, I mentioned earlier, also chemotherapy for any kind of malignancy or radiation, any cause of chronic diarrhea, any cause in general. There is also rare xanthiuria. They have, this is rare autosomal recessive. I haven't seen any cases myself, Kuwait or Canada. It's very rare, it's autosomal recessive. Struvate stone, as you all know, it usually comes with a urine tract, or they have a urine tract infection or pyelonephritis. They occur in, they have some bacteria like Proteus, Klebsiella, and Pseudomonas, the Serratia. They can produce enzymes, urease enzyme, break down the, it's bind solely, bind with the, break down to ammonium, and then it bind with the magnesium, calcium, and form the struvate stones. And usually they are rapid forming, and they are the only they are the only stone who actually develop in alkaline urine, not in acidic urine, precipitate faster. And they are also less radio-opaque than calcium stones. Some bacteria, as I mentioned earlier, and others like Yersinia and Klebsiella and ureaplasma bacteria. And they are classic to have, if you can see, coffin lid crystals in the urine analysis. You can see them. And they are also known to have staghorn stones. I only saw them in X-rays. Actually, I'm sure you guys saw them in the gross front of you.
We have 3 minutes.
And you can see them in the picture here. There is also cystine stones, very rare also disorder. Usually they come in family, autosomal recessive. A very frequent former of kidney stones. Very pathognomonic to have hexagonal shape in the urine analysis. Their treatment, this is general treatment, also increased fluid intake, alkalization of the urine. And there is also chelatic agent. There is 3 generations, benzylamine, and there is thiopronone and butylamine, only available in Korea and Japan. There is all chelatic agent. Sorry. And there is a new also agent, L-cysteine dimethyl esters, very effective. Their evaluation of recurrent kidney, this is only recurrent kidney stone, calcium levels, renal function, electrolyte, bicarbonate, urine analysis, urine culture, uric acid levels, full renal function, stone analysis of the patient able to catch the stone, CT, and plus or minus ultrasound of the patient is pregnant. For 24-hour urine, we need to have correct sampling, check creatine, also sodium, citrate, oxalate, uric acid, cysteine if they have family history, pH, and creatinine, and calcium. These are the normal values. Imaging modalities, it used to be IVB, but now called standard non-contrast CT. Myself, I always order ultrasound first. General treatment is target urine output 2 to 2.5 liters per day. This is ideal. If they keep doing this, they have less chance of having another kidney stone attack. Limit sodium intake, maintain normal calcium intake in the diet, decrease animal protein. And this is specific for uric acid, already mentioned. For struvate stone, they can use AHA. It helps in severe cases, not responding surgically. Make sure they have at least 2 liters of urine per day. Add fresh lemon. This is general for all patients. Fresh lemon to drinking water. Avoid carbonated drinks. less than 6 grams of salt per day, and maintain normal calcium intake by diet.
1 minute.
Potassium citrate for any patient whose all his urine workup become normal, it have to be, we can give them potassium citrate. Last, the medical expulsive therapy, we can use calcium channel blocker or alpha blockers. There's a famous suspend trial, found no benefit. However, in the NICE guidelines published 2019, January, they recommend to use alpha blocker, and the reason is basically financial. So the reference, thank you.